gram-negative group of microorganisms. These are Burcella, Bartonella, and pasteurella, Francisella, and yersinia. Now, starting with Burcella, and I think we came across this one in one of the lab sessions when we talked about Helicobacter and related species. So, as you might remember, that it is intracellular, and it is the one responsible for the undulant fever or Malta fever, and it is non-motile, fastidious, as we said, gram-negative aerobic coccobacilli. So the transmission is usually through unpasteurized milk or milk products, dairy products, and particularly cheese. So these are considered as a common vehicle to transmit the disease. Infective dose is as low as 100 microorganisms can cause brucellosis. By the way, brucellosis and typhoid fever, both of these are endemic in Iraq, and they're quite common. There's also in the lecture is also, it's very important to know the main species, and we have the Burcella melitensis, Burcella abortus, Burcella suis, and canis. And the most common cause is the Burcella melitensis, okay? And there is a wide range of preferred animal hosts, sheep, goats, or camels. And the biovars, number of biovars are 3. And the clinical disease, is, as we said, is called the Malta fever or undulant fever, Hummat Malta. It is very common in Iraq. Incubation period from 1 to 4 weeks, and with both cellular and humoral immune response being activated. And the type of fevers, speaking of fevers, because now we are reaching the final lecture in microbiology course in bacteriology and mycology. Now it's very fitting to talk about some kind of fevers that you might have already known or studied. It's very important if you can follow me here with the, I hope that all those students that came in recently, they go to the link in the chat box to the Jamboard. We go now to the different types of fevers, as you can see here. I hope now, is it clear? Do you see the types of fever types slide?
لا دكتور ماكو على صراحة.
Okay.
دكتور موجودة بالرابط قزاقات؟
In the link.
نعم دكتور باللينك موجودة.
Okay, so please, if the student that said no, can go to the link provided in the chat box and click that link, and you are going to see the slide. The slide is the fever types.
دكتور العفو تقدر ترسله مرات الأخرى لأن يعني دخلت معكم موجود كان.
Okay, and now I will change the way of sharing the slides. Wait a minute. I think it's not that convenient because some students will come later and they don't find the link also. So maybe better to share it right away. Okay, now I think all of you can see. Okay, so do you see now the?
نعم دكتور موجود.
Okay. Wait a minute. Now so the fever types we have The one typhoid fever is continuous one, as you can see. So here this horizontal line represents the baseline temperature of a human body. And the type of fever is gradual onset in case of typhoid fever, as you can see here. So it's starting below the baseline and then going up, reaching the plateau, and then it will go down also gradually. It is in contrast with the typhus fever. Now we are talking today about the multi-fever, andulant fever. As you can see, it's totally different. It's a gradual and sometimes can be abrupt, but it is called andulant because of this wavy shape of the fever. It goes up and down and again up, and the next day and so on. So it is called andulant. So because it changes in days and during the day, it's called andulant. And this is very important to recognize because it can give you some hints about the type of disease or infectious disease. In case of typhus, as you can see, it's an abrupt onset and continue and then gradually, suddenly will drop. And this is the typhus, typical al-humma al-namashiyya, okay, that we discussed in the previous lectures by Rickettsi. Now, the remittent fever, which is, we are going to talk about it in a while. This is called also the trench fever. And it's not, as you can see, this fever is changing also in sudden and abrupt, and will be recurring every 5 days. And it is the trench fever. There is also no touching of the baseline. There's also intermittent fever of the malaria and the relapsing fever, which is characteristic of Borrelia infection, sudden onset and then disappears. Okay, so these are the fever types, very important to know. And also, the diagnosis for multi-fever in Iraq is usually done by serology. Rose Bengal test is a very common test. And rising titer is an indication of the disease. Also can be another test, the serum agglutination test or SAT, and titer of 1 to 160 is considered diagnostic if it agrees or if the case is present in an endemic area, like in Iraq, for example. And titers above or equal to 1 to 320 or higher are considered diagnostic. Because the organism is fastidious, it's difficult to cultivate and culture, and also it carries some risk. Therefore, serology is the diagnosis of choice, or the diagnostic method of choice. Now, treatment. The organism is intracellular and it requires prolonged antimicrobial therapy. Combination of doxycycline with streptomycin for 2 to 3 weeks or rifampin for 6 weeks is recommended. Okay, now the control is usually because of the transmission is by milk and milk products. So best way to control this disease is by pasteurization of all milk products and also active animal immunization. Now we are done with the Burcella. Now we can go to the other one, the other gram-negative bacteria that is called Bartonella. Bartonella is different in the way that it is also called hemotropic. So don't forget this term, hemotropic, because tropic means affinity or favors the RBCs and blood. Because it favors the RBCs and the blood, it is called hemotropic. And it can parasitize the erythrocytes and endothelial cells of mammalian hosts. And they are very adapted to be intracellular. Okay, so this again intracellular organism like in Burcella. They are facultative, intracellular, and fastidious organisms. Again, they are difficult to isolate in the lab. And however, they can be visualized using special stain, Warden, Starry, Silver impregnation stain. And we have 3 different species, which are clinically important. First one is Bartonella bacilliformis, and which is the one responsible for Bartonellosis or Carrier's disease. The host is humans, and there is a vector for it, which is the sandfly. The other species, which is called the Bartonella hensley, it is the one responsible for the cat scratch disease. If you now see this slide, this one is the cat scratch disease. And it is benign, self-limited disease caused by Bartonella hensley. And the presentation of the patient, beside of this primary skin lesion, either as a papule or pustule, this will develop at the site of entry, if you still remember, by the vector, by the bite of the sandfly, about 3 to 10 days after exposure. So there will be a history of some vector bite, and also this primary lesion at the skin examination. It also could be associated with lymphadenopathy, and which will develop within 2 weeks after history of contact with a cat or by a flea bite. Okay, so this is the not by the sandfly, sorry, but by the cat fleas. Okay, so these are associated, the cat scratch from its name, associated with the cats, either directly or from the cat fleas. Okay, and this one is, as we said, caused by Bartonella hensley. It is self-limited, and also it can, the lymph nodes can be enlarged and can be tender, painful, and they can disappear within weeks or even months. However, this might change and may be associated with suppuration and pus discharge. The diagnosis is based on history of cat contact or bite by cat fleas, physical findings, and also aspiration of pus from the lymph nodes, histopathological findings. There will be granulomatous lesions. And there you can visualize, as we said, the microorganism, Bartonella, by using the Warden Starry Silver impregnation test. And finally, there is serology by indirect immunofluorescence tests. When we say indirect, means we are looking for the antibodies, and which will support the diagnosis with a titer of 1 to 64. And also ELISA test can be utilized for diagnosis. So this is for cat scratch disease. Now back to the Bacillus bacilliformis, the Carrier's disease. It is called after the scientist or the one who Carrier's. His name is Daniel Carrier, and the one who ingested himself with the microorganism and passed away just few weeks after ingestion. And then afterwards it was discovered, and then it was called after the name of that scientist. So here we see in this Carrier's disease, there are 2 phases. The initial phase is called the Oroya fever, and Oroya fever is a serious infectious anemia. Anemia, why? Because, as we said, the Bartonella has affinity tropism to erythrocytes and destruction of the erythrocytes. The second phase is the eruptive phase, and it's called the Verruga parwana, and it commonly begins 2 to 8 weeks after in exposure, with or without the fever or Oroya fever. So fever is not always associated with the the other or the eruptive phase. Okay. Now there will be hepatosplenomegaly and hemorrhage to lymph nodes, again because of the affinity of the microorganisms to go infect and destroy RBCs and erythrocytes. And also in the histopathological finding, there will be a very characteristic masses of Bartonella bacteria filling the cytoplasm of cells, lining the blood vessels, and they can be all lead to vascular occlusion and thrombosis. Mortality rate is about 40% if left untreated, and diagnosis is by blood smears and blood culture. So the verruga peruana appears as a vascular skin lesion. So this is a skin manifestation and eruptive, and they occur in successive crops, and they last about 1 year with little systemic reaction. So in this case, in this phase, the verruga peruana, it's very important to remember that the Bartonella can be seen in the granulomatosis lesions, and the blood culture can be positive, but there is no anemia. So in this phase, it is not anemic, it is not acute. It is the one that is, let's say, it is chronic, verruga peruana. Here there is no the anemia that we have seen in the Oria fever phase, so it's different. And the Carrier's disease can be treated with antimicrobial therapy with or without blood transfusion because, as you said, because of the anemia, to reduce the mortality rate. Okay, and the prevention, because the sandfly is associated in the infection, so elimination of the sandfly vectors with insecticides and insect repellents can be good methods to control. Now, the third species in this group, it is the before we go to the other microorganism or other disease, the Bartonella quintana, and the name Quintin from the Quintin fever or trench fever. It is called trench fever because it was first recognized as a disease in the trenches in the World War I, and because the soldiers in the trenches were exposed to different bites and also and lice, and as a vector, and then exposed to the Bartonella microorganism because of the poor hygiene, and so that was the reason why there was a pandemic, and because of the poor hygiene and rapid transmission of the disease among soldiers and the World War I. Therefore, it was called also the trench fever. And also, it was observed and noticed that the fever continued or were recurring every 5 days. So they were like present for 4 to 5 days, and then we go back after 5 days. And this recurring pattern every 5 days is also called a quintin. So quintin meaning recurring every 5 days. So therefore, the other name is the quintin fever. If you go back to the slide, and we are talking about the trench fever here, type C. So this is a recurrence, but it is not touching the baseline. So it is always above the baseline, but there is that recurrence every 5 days. This will recur. So disappear 5 days, and then will appear 4 or 5 days. So this is quintin. Okay. Now, The treatment is gentamicin and doxycycline to eradicate the microorganism and to prevent complication like endocarditis. Now there is a disease entity which is called the Bacillary Angiomatosis, as you can see here in this patient. It is characterized by this primary skin lesion and prominent finding. Here it is can be caused by both Bartonella hensley and by the other species, the Bartonella quintana. So both of these species can lead to bacillary angiomatosis. It is usually present in patients who are immune suppressed, immune compromised, either old age or taking immunosuppressive drugs for whatever reasons, or have some immune case of or state of immune suppression for whatever reason. So here it is associated with such individuals. And also it is very important to remember that cat scratch disease occurs only in immunocompetent individuals. It's self-limited disease. It is different here in this case. In bacillary angiomatosis, it is caused by these two species and in immunocompromised patients. Histopathologically, it is characterized by circumscribed lesions with lobular capillary proliferation and round open vessels with cuboidal endothelial cells, and these are protruding into the vascular lumen. The presence of epithelioid histiocytes is very prominent finding, surrounded by loose fibromyxoid matrix. In this matrix, we can see a bunch or colonies of microorganisms, and can be stained, by the way, by the Warden-Starry stain, which is a special stain. And the lesion, this lesion usually, while in this immune suppressive patients, will look like Kaposi sarcoma in AIDS patients. It looks like Kaposi sarcoma, but histopathologically it is totally different. And it is also, there is also involvement of liver and spleen, and characterized by proliferation of cystic blood-filled spaces surrounded by this fibromyxoid matrix, and this matrix containing the bacilli. So this form of disease is called the pileosis hepatis, okay? And usually accompanied by fever, and we said this fever is recurring, weight loss, abdominal pain. The diagnosis, as you can see, it's based on histopathology and the demonstration of the bacilli using the silver-stained special stain, and serology by using indirect immunofluorescence because of difficulty in isolating the organism in the lab. Okay, so treatment can be treated with erythromycin, doxycycline for a minimum of 2 months. Okay. Now this is with Bartonella. We go now to the third genus, which is the pasteurella. The pasteurella, again, is a gram-negative Coccobacilli. It is non-motile, and they show the bipolar appearance. By bipolar appearance, it is meant that by staining, we can see that 2 ends of the rods are deeply stained than the central portion. So this is called the bipolar appearance. So the staining will be at the ends of the microbe of the rod. And this appearance can be better demonstrated using the Ginza stain. Okay, so these are aerobes or facultative anaerobes, and these are both catalase and oxidase positive. There are species also mentioned in the lecture, and these are zoonotic. These are primarily animal pathogens, but they can cause a range of human diseases. So again, it is zoonotic disease. And the clinical finding is usually there will be the diagnosis based on history. There is a history of animal bite because they are in animals. So animal bite can be suggestive. And then there will be acute onset of redness, swelling, and pain. Regional lymphadenopathy is variable and can be associated with low-grade fever. Okay? It can be presented as bacteremia, which means the demonstration of microorganisms in the blood, or chronic respiratory infection. And also, a treatment is there is no special resistance or antimicrobial resistance here, so they are susceptible to most antibiotics. And penicillin G can be the drug of choice for treating infections by animal bites. Okay, so that was pasteurella. For Francisella, the species, these are present in the animal reservoirs. Again, it is a zoonotic disease and also present in aquatic environments. We have three species. We have Francisella tularensis type A. And also you have a table for the different species. For example, we have Francisella tularensis polarctica type B, and we have Francisella tularensis mediasiatica. Okay, so these are the three different species. And in the table, you are going to see the preferred animal hosts and also the severity of infection. The clinical feature, actually the Francisella is responsible for a disease called tularemia, and it is a zoonotic disease. The clinical feature depends quite on the route of infection. And in page 5, you are going to see a table against the type of tularemia. It all depends on the route and what are the features associated with it. So for example, we have one form of tularemia, and it is again, the tularemia is when it is only when it is only confined, restricted to lymphadenopathy, it is called glandular. But whenever there is a skin ulcer, then it will take the form of ulceroglandular. Okay, and also the route here in both cases will be by skin, by insect bite. Okay, so again there is history of bite and through the skin. Now, if the route will be inhalation of infected aerosols, then the form will be pulmonary tularemia, and it will be presented as atypical pneumonia. If by ingestion, then oropharyngeal. If conjunctiva, then ocular granular, and so on. The typhoidal type is by ingestion or by bacteria through blood. Here there will be fever without apparent skin lesions. So in typhoidal form, okay? It is not typhoid, but it has the typhoidal form, okay? So it's very important to make a distinction. Now, diagnosis is by serology and paired serum samples collected 2 weeks apart. So you take first serum sample, and then you take another one after 2 weeks, and there should be a rise in agglutination titer. Okay. Because of cross-reaction with Burcella, so the tests, both of these tests, I mean, serology for brucellosis and for tularensis or for tularemia should be done, especially in areas where both are suspected, and for fold rise in whichever titer which will indicate the cause of that disease. So if you have a higher fold increase, it means this current illness is due to that to that microbe. to which these antibodies are directed. Now, treatment is by using streptomycin, gentamicin for 10 days. And also, there is some resistance by Francisella tularensis to beta-lactam antibiotics as a result of beta-lactamase activity. Now we go finally to the last species, genus, the yersinia, which is the one responsible for the plague, Barton. Okay. Now, this is one of the manifestations of plague, as you can see here in this image. Here there is blackening, and sometimes it's called the Black Death because of this dead tissue. And here in the fingers, toes, or the nose, and what will be occlusion of the blood supply and necrosis, death. And also sometimes it will take different forms. The one responsible for this is the Yersinia pestis, and it was the one responsible for 3 very known historical epidemics. So the first one was in about 541 to 542 AD, and the second epidemic was in the 1346 and 1300 to 53. That was the second epidemic of a plague, and the third one in 1885. So the 3 historical epidemics and led to high death toll numbers and very widespread death, and it was very horrible. And because of the way of the patients suffered, and also how they passed away, the Yersinia pestis is a gram-negative road with bipolar staining, with Giemsa stain, giving the hairpin appearance under a microscope. It is non-motile, facultative anaerobe, and can grow on many bacteriological media, including Maconchi agar. And actually, they are going to be pale. They will give pale colonies, and growth is more rapid on blood agar and fastest at 30 degrees rather than 37. Very important. The causative agent is the microbe, but it is a zoonotic from wild rodents. So rodents play a key role in transmission of disease to humans via flea bites. So again, here there will be vectors, flea bites, and animals, rodents, and the microbe in order to be responsible for that disease. And it is the only microorganism in Enterobacteriaceae group that is known to be infected to humans from animals by insect vector. So this is I think, very peculiar in this aspect. Now, the pathogenesis is very important that you should know in rodents. First, the rodents will be infected by Yersinia pestis, and the transmission of the microbe now from rodents to humans by flea bites or by fleas. Now, the first thing is that the fleas will ingest, or teeth will be infected by these microorganisms, and the Yersinia pestis bacteria will multiply in the gut of the flea. It will lead to blockage and by coagulase enzyme, and this blocked elementary or let's say the proventriculus, and so the flea will be suffering from blockage and therefore non-nutrients in this case, so it will be very hungry, and the bite will be very ferocious, and the contaminated blood with Yersinia pestis from the flea is due to biting very hard, and it will lead to blood is going to come up, and there will be regurgitation into the bite wound. Okay, and of the microorganism will go and enter into the human by the bloodstream. Organisms, the pestis can be phagocytosed and killed by polymorphonuclear cells, but multiply in macrophages. So they are multiplying, and because of the temperature 37, they can resist the phagocytosis by producing antiphagocytic protein. Now, the pathogen will be in the lymphatic system and also can reach to bloodstream. In the lymphatic system, it will lead to enlarged lymph nodes and with necrosis, and also the invasion can stop there or can reach the bloodstream, and here at this stage it will become widely disseminated. It will lead to hemorrhagic and necrotic lesions in all organs. No organ is immune, leading to meningitis, pneumonia, or even so death. And the blackening or the black appearance, as we said, is due to the gangrene, and mostly in extremities, fingers, toes, and nose. It is one of the main hallmarks of the septicemic phase, where we said the microbes is disseminated. And the pneumonic plague. So there are clinical few findings you are going to see in the lecture. We have bubonic plague. Usually this is with the involvement of regional lymph nodes, which are called, when they become large and tender, painful, they are called buboes. Buboes, so enlarged, tender lymph nodes. This is called the bubonic plague. Now we have another thing, another form is the primary septicemic plague, associated with vomiting, diarrhea, and disseminated intravascular coagulation, leading to hypotension and altered mental status. This is septicemic. So there is dissemination, and there will be demonstration by blood of the microbe in the blood spheres. There is another form which is called the pneumonic. It is by inhalation, and incubation period from few hours to 7 days. The sudden onset of fever, headache, and respiratory signs and symptoms. There is also meningeal plague, and also there is pharyngitis. The diagnosis, there is history of exposure to rodents in endemic areas. Now it's very, nowadays plague is very rare, and also it's only in certain areas. Therefore, the vaccine is not needed. And it is usually, the culture can be very highly infectious, so should be dealt with cautiously and only in lab provided with biosafety level 3 practices. I hope that you still remember what BSL3 means. And if you still remember the in the lab sessions, the different BSL levels or biosafety, biological safety levels. Okay, and the treatment, there is a mortality rate of 50%, and for pneumonic plague about 100%. Therefore, there should be prompt treatment whenever the Black Death is suspected. Streptomycin is the therapy of choice. Gentamicin, doxycycline, and fluoroquinolones like ciprofloxacin are effective alternatives. And usually, as we said, cultures are dangerous, so it should be dealt with cautiously. No established vaccine is available, although vaccine is there, but there is no sure results of its efficacy. The other species among Yersinia is the Yersinia enterocolitica and Yersinia pseudotuberculosis. And these are two. They can grow best at 25 degrees, and there is the way of transmission. They are responsible for gastroenteritis and mesenteric lymphadenitis after ingestion of these microbes by contaminated food or water. Okay, they can be seen from the stool using special media called CIN agar, incubated at room temperature. Okay. So most Yersinia infections with diarrhea are self-limited and requires no treatment. Okay. And if a treatment is necessary, then these are going to be susceptible to trimethoprim, sulfamethoxazole, doxycycline, or fluoroquinolone antibiotic. Okay, so that's it for today's lecture. We come to the end of it. Please, if you have any question, just tell me about it, and glad to answer it. Okay, so